when people from lower income communities visit, say, a grocery store, they are likelier to be visiting grocery stores that other people from lower income communities visit as well. Right. So there's this sort of self-exacerbating effect, the self-fulfilling prophecy where if one group already has more infections, they are likely to continue having more and more infections than the other group because they tend to mix more with people from their own group than people from the other group. That's one thing that makes infectious diseases especially prone to these sort of inequalities because you have this self-exacerbating effect. Hi, everyone. I am Dr. Serina Chang. I'm an incoming assistant professor at UC Berkeley, and you're listening to the Public Health Insight Podcast.
From PHI Media, I'm Gordon Thane, and this is AI and Public Health, Episode 239, Disease Spread Explained Through Novel Data Sources. You're listening to the Public Health Insight Podcast, your go-to space for all things public health and global health, from the Sustainable Development Goals to the social determinants of health, as well as interesting dialogues about the diverse career opportunities that exist in these fields. Remember to subscribe to the podcast and leave us a rating on Apple Podcasts and Spotify so other people like you can benefit from our content. Over the last 2 episodes, we spent some time with Dr. Serina Chang to better understand the foundational concepts in the artificial intelligence space and the power of computational methods. Dr. Chang is an expert in computational health, and she'll be an assistant professor at UC Berkeley in 2025. Her work has also been featured across a variety of popular media outlets like the New York Times and the Washington Post. Now, what we want to know is, what is in this for us? People use generative AI like ChatGPT to help with assignments, make itineraries for their trips, co-create outlines for podcast episodes, but it all feels a bit superficial. After all, we're public health professionals, and so having a vision for how we can use these game-changing tools to advance population health is what appeals to us after all. To illustrate this point, Dr. Chang walks us through a real-life example of how AI and computational methods have been used to solve real-world problems with consequential impacts on public health. Let's jump back into the conversation. I was fascinated by your research on the mobility data and the intersection with COVID, and how I think you gave that example about looking at communities that were predominantly white versus communities with more ethnic minorities. And then the assumption, it's sort of widely accepted now that people of color, ethnic minorities, and marginalized populations were disproportionately impacted by COVID. And the undertone to that is the same kind of reason that we use for other things. Oh, the comorbidities, the social determinants of health, and that sort of thing. So it was really fascinating to see how you actually linked it more from human behavior from a mobility perspective, and then using that to be able to predict based on things like overcrowded grocery stores and things like that, as one of the main reasons why there was different disease transmissions in certain communities. So maybe you could speak about, I think that's a fascinating application.
Yeah. Let's talk about that. So this project was from around 2021. What we did was we were using, and this is a common theme in both my public health and social science work, we are using novel data sources to try to better understand behavior on the ground. And so I've worked with, say, mobility data from aggregated location data. I've also worked with search logs. I've worked with social media. I'm interested in news articles and political speeches. There's just all of these really rich data sources that are generated directly from people where you can understand their behaviors a lot better. But so specifically in this project, we were using this mobility data so that we could better understand how people were moving around in the first wave of the pandemic. And so we constructed these large-scale mobility networks that encoded the movements of people from individual neighborhoods to individual points of interest. So points of interest are public locations, like a single restaurant, a grocery store, a gas station, et cetera. And we were able to reconstruct these networks based on publicly available location data. And then once we reconstructed these networks, then we simulated the spread of COVID over the networks. And so what was really valuable about these networks is because they were at an hourly granularity, we could say who was visiting where at the same time, and then model the spread of COVID based on their sort of co-visiting patterns. And so if one neighborhood was highly infected and another neighborhood, they had a lot of people going to the same restaurant at the same time, then there could be some transmission from the highly infected neighborhood to the other neighborhood that was visiting the place at the same time. So that's the basics of our model. And based on this rather simple model, and so we used complex data, but very simple modeling, we were able to match actual COVID cases in 10 of the largest metropolitan areas in the US during the first wave of the pandemic. And we were also able to do some short-term forecasts. So that was sort of the model validation. But the exciting part is once we fit our model, we were able to then retrospectively look at the mobility patterns and better understand how those mobility patterns inform both health disparities, as you were saying, as well as reopening plans moving forward. And so to understand the health disparities, what we first noticed was that, like I said, this model was very simple. The model that was modeling the spread of COVID, it was basically saying who is where at the same time, and based on some probabilities, we will model that you transmitted. The model was very simple. It only took in mobility information. It didn't know anything about for example, the demographic makeup of each neighborhood. It didn't know which neighborhoods were predominantly white and which ones had more ethnic minorities or more marginalized populations.
And was that intentional?
That was intentional because then we could analyze this very fact, which was without knowing these things, it still correctly predicted in all 10 metropolitan areas that we studied that more disadvantaged populations were getting infected at significantly higher rates. So this was both lower income communities as well as more ethnic and racial minorities. And so this was a consistent fact. And so then what we wondered was, since the model is only taking in mobility data and it's still reproducing these disparities, what is it about the mobility data that's telling the model this? And we realized that there were two mechanisms that could explain this finding. First of all, is that these disadvantaged communities were not able to reduce their mobility as much early in the pandemic. And so if you just plot out how much mobility is there per capita, so just how many visits per person for each neighborhood, you see a drop for both, let's say, higher income and lower income communities early in the pandemic, but the drop is bigger for higher income communities. And this remains true throughout the first few months of the pandemic. This is also true across all of the metropolitan areas that we studied. And so we don't know this for sure from the data, but you might hypothesize that this is because lower income groups were less able to socially distance. Maybe they were working in essential worker jobs, and so they couldn't just stay at home all the time. And so the sort of social distancing, just the rates of social distancing were different across groups.
And the method, I guess the method of mobility, maybe public transit. I'm not sure if that plays a part there too.
Yeah, for sure. Like maybe they had to rely on public transit more. So so basically they still had to go out when maybe more advantaged people could stay at home and hide from COVID. The second mechanism was it's not just how often you go out, but where you go to. And I think this is the finding that you were suggesting, which is we found that even when you control for the type of place that people are going to, so the type of place being like a restaurant or a grocery store or a gas station, even when you control for the type of place, lower income and racial minorities are going to these points of interest that tend to be smaller and more crowded, and they have longer wait times. And so, for example, for grocery stores, we showed, I think, the difference between higher income and lower income communities. The grocery stores that lower income communities were going to tended to be 2 times riskier under the model. And so the model is determining risk based on a combination of what is the area in square feet of the place. So smaller places are riskier. We also had data on how long do people spend at the place once they visit. And so, for example, if there's a long wait time at the grocery store, or maybe you're at a restaurant, you're going to spend more time at a restaurant than you would at, say, a gas station. And so we had what's called the median dwell time of how long people dwell at the place when they visit. And so we had information like that. And then on top of that, when people from lower income communities visit, say, a grocery store, they are likelier to be visiting grocery stores that other people from lower income communities visit as well, right? So there's this sort of self-exacerbating effect, the self-fulfilling prophecy, where if one group already has more infections, they are likely to continue having more and more infections than the other group because they tend to mix more with people from their own group than people from the other group. That's one thing that makes infectious diseases especially prone to these sort of inequalities because you have this self-exacerbating effect.
That was a fascinating, because initially I thought when it was mobility, it's like, oh, is it something? So I guess let me backtrack a bit. How do we get that mobility data in the first place? Is it from phones? Is it from from
so
phones?
It's usually anonymized aggregated data from cell phones. And so, for example, when it was given to us, it was aggregated over these neighborhoods. So these are census block groups that typically contain 600 to 3,000 people. It's like a census unit. And we could see out of that census block group how many people are going out each day. And then also for each point of interest, we can attribute visits to the points of interest to say in every hour how many people are visiting each point of interest. And so there are these third parties, like SafeGraph is the one that we were using. They were actually providing this data for free to any researcher during the pandemic. So a lot of people saw mobility data as this opportunity to really understand mobility on the ground, which is so essential to pandemic control, especially before we had any vaccines. Like non-pharmaceutical interventions like social distancing were really the only thing that we had. And so trying to understand how people are actually behaving on the ground was very essential.
I think the way you explained it is a very practical example of how the public might want to see decisions being made, being evidence informed like this, where there's real world data that exists that can inform what reopens first in the case of COVID, when it reopens, what the capacity limit is, the operating hours. I think you kind of talked about as well. So I think it's a cool tool. Not cool, it's maybe an understatement. It's a fascinating tool that decision makers can then use to make decisions based on real world consequences that we get through these vast data that we have. And then the second piece of it that I find fascinating as someone that's in the public health space, and without these AI tools, we're very limited in terms of the data that we can collect, right? We rely on hospital data. We rely on, obviously, prevalence and incident, and we rely on self-report data from survey and focus groups. And there's just an over-reliance on those traditional ways of collecting data. And then what you just shared is how AI can unlock novel sources of data that can tell us a lot about human behavior in a way that allows us to predict disease spread, for example, predict movement, predict how people interact with each other, and then the consequences that come out of those interactions. So
Exactly.
Really cool.
Yeah. So I am very excited about these sort of novel data sources, both from an AI perspective, because they do come with their own challenges too. And so developing AI methods that can handle these sort of massive data sources, but also the sort of insights that they can give us about human behavior and how human behavior then leads to different public health outcomes.
In your line of work and interacting with people from different disciplines, different levels of understanding of the work that you do, different understanding of what AI can do and what it can't, do you ever encounter any kind of pushback from what you, and then how do you address or handle those types of conversations in terms of when you think of things like the state surveilling the public, the privacy concerns, and the paternalistic state, and as much as it allows other novel data sources, it comes with a public perception of maybe what that could mean in the future. So how do you, as a, like you said, a computer scientist, data scientist, public health professional in academia, in that type of space, when you're building these tools and showcasing the use cases for them and the limitations, how do we communicate about such nuanced things in a way that kind of doesn't really scare people, and a way that acknowledges the limitations and risks?
Totally. Yeah. And I think this is a great question. And I think it's not just pushback, but valid criticism that I think we need to work with. Privacy is a huge question when you try to do these kinds of things. Like mobility data is taken from cell phones. It's often from apps where maybe they asked you explicitly, maybe they didn't, of whether they're going to collect your location. And so it's like opt in or out, and there might be defaults that are a bit sneaky. And so this kind of data is definitely extremely useful during pandemics, but also comes with these sort of risks as well as ethical concerns. And so a couple of things. I mean, I think the first thing is aggregation. So that is one thing that can help with privacy. And so, for example, we only use data aggregated over these entire census block groups, so 600 to 3,000 people, never using the individual data sources. So an individual person's mobility is quite private. And actually papers have shown that from an individual person's trajectory, even if it's anonymized, you can quickly identify a person based on a couple of points that they go to.
Right.
And so really trying not to use that sort of individual mobility data and staying at the aggregated form. And I think thinking about when you stay at the aggregated form, what are the sort of insights that you can still draw? And I think in our case, like we didn't need the individual data. We could still find these claims. So for example, looking at disparities between the neighborhoods, it was actually a more meaningful analysis to do it in the aggregated form. Yeah, instead of saying like this individual has this income and that's how they're behaving. Like you do want to already do this analysis at the aggregated stage to say these neighborhoods that have higher median income, and then to compare across a lot of cities also to see whether that result holds. And so thinking about what can you learn from aggregated data and what kind of insights can you draw. So I think that's the first thing. I think a related thing is only using what you need. And so it's not just like it goes both ways, right? So let's say you assume that you need aggregated data. And so then you think about what kinds of questions can I ask from aggregated data? But also in the opposite direction of saying, okay, I want to answer these questions. What is the most privacy preserving kind of data I can get to answer these questions?
Gotcha.
And so you could also think about it that way. Like if you wanted to say what are differences across communities in terms of their mobility patterns, you don't need individual data to answer that question. Relatedly, we did some work on search logs to try to understand people's vaccine patterns. There, we did need individual level search logs so that we could, I can explain that project a little bit more, but we didn't need, say, individual level demographics on people. Again, we could still use like their zip code level demographics. And we can also lump people into large classes of what we call vaccine holdouts versus early adopters instead of studying people's individual search patterns. And so I think being really aware of only using what you need. And then I think a final question is from an academic as well as a practitioner's standpoint of really thinking about what are the trade-offs between utility and privacy. And sometimes there aren't even trade-offs. So sometimes being really aware about what are these questions you're asking. To give you a concrete example, let's go back to the mobility network. And so remember, our mobility network was encoding the movements of people from neighborhoods to individual places. You could also imagine an even more aggregated network, say between counties, or you could imagine a much less aggregated network like the mobility network between individuals. So you have each individual's patterns and which points of interest they're visiting. And when you think about these different levels of aggregation from the individual to the census block group level to the county, each time you aggregate, you do lose some sort of information. So you do, like when you're aggregating, you're basically treating everybody within the aggregation the same. So you're treating everybody in the census block group the same, or you're treating everyone in the county the same. And
so you lose the variability within the group. Too.
Exactly. And so how bad is that, basically? Like, what is it? How bad is it to treat that entire group the same? Well, what you're losing is, as you're saying, you're losing variability within the group. And so, for example, maybe within your census block group, if you had one super spreader who like was going out and about to all of the points of interest, and then everybody else just stayed home all the time. Once you aggregate over those people, you can't tell them apart anymore. And you would assume all of those visits that the one super spreader made were actually distributed evenly over all of the people within the group. And so I think being really clear-minded from real data of what is it that we lose every time that we aggregate, and then what is it that we gain on the decision maker side. And so if you're a decision maker and you want to ask like a really high level question, like should I lock down the entire city or not? Then maybe at that point, it's not so important to capture the variability within each group. Like at that point, maybe the county level network is enough. But if you want to do something really, really like quite fine-grained, like so we were working with the Virginia Department of Health, and they had one question, which was where should we actually place mobile vaccine sites? And they wanted it down to like the block, essentially. So the physical locations of mobile vaccine sites that are carrying, say, the Johnson & Johnson vaccine. At that point, you do need more than county level data so that you can get the granularity of the intervention that they're trying to do.
fascinating stuff. So I could talk to you for another couple of hours, but I don't think that would be fair to you, and I would break my promise of a 90-minute session. So I'm going to leave you with this question.
Yeah.
When it's all said and done, based on your current perspective,
Mm-hmm.
do you think AI will have a net positive benefit on society or a net negative benefit, considering all the different players, the limitations in regulating the unknown to a certain degree, and that obviously you throw capitalism in there? Are you more optimistic or more pessimistic?
Yeah, I think I am still more of an optimist. I mean, my entire research agenda is centered on AI for social good. And so I think I have to be an optimist to continue doing that work. I think that said, there are these, I think, low probability but scary risks of AI really destroying society. And so I think we need to keep our eyes on both, right? Like I think AI creates all of these opportunities to do stuff that we couldn't do before. Like I didn't talk about generative AI for public health as much, but I think one really valuable thing is, for example, maybe developing chatbots for health and for helping people who don't normally have access to, say, doctors or medical professionals in their family, of making sense of their own health as a certain like first stop for people. And also a later stop, like maybe once they actually do have seen the doctor and they have diagnoses, to make sense of the things that they learned, like basically to have someone that can explain things to them, but as a chatbot. Of course, there's a lot of risks to that as well. And so that's why we need to keep our eyes on both the opportunities and the risks at the same time. So, for example, generative AI is not known to be completely accurate. And so if you want to use ChatGPT as a chatbot to talk to you about medical stuff, that's quite important, that it's giving you accurate medical information instead of doing what's called hallucination, which is like coming up with facts or coming up with sources. So I think that's a risk. I think in the public health space, misinformation is another huge risk. Generative AI makes it possible to produce very realistic looking articles at scale that are just spreading massive misinformation. You've probably heard of deep fakes as well. Like it can actually create pictures of people that make it look like they're saying something, or videos that make it look like they're saying something that they're not. And we already had concerns about misinformation during the COVID pandemic, but now with generative AI at scale, you could imagine misinformation spreading much, much faster. And so I think there are both these really exciting opportunities, which are all of the things that we described during this episode, but also these risks, especially when we focus on generative AI and health. So I think we need to keep our eyes on both things. Like, don't lose sight of the opportunities when you're only focused on the risks, but also don't like jump on the hype train too much either. Like as you're releasing these things, as you're seeing them progress, also always having a very critical and also very evaluation driven standpoint of thinking like, how do these things work and how are they actually affecting society?
That was my last question, but I have to ask a follow-up just because I'm curious. Is there value? Because I've seen a lot of big players in the AI space who are actually kind of scared of maybe things that they were involved in creating, and they're, we need to pause, shut it down until we understand. And then there's the school of thought of kind of keep pushing and going and kind of see where the limits are. Is there something to be said for pushing the technology to its limits so that we can understand what could be harmful and mitigate those, as opposed to waiting until it comes up? You almost need someone or an entity to like push it to the limits to proactively build policy and regulation around it, instead of waiting for it to happen and try to put the cat back in the bag. Because that's happened a lot of times for different things. If you talk about the tobacco industry with vapes, and we're so focused on cigarette smoke, and then vape comes out of nowhere. We don't have a regulatory framework for it. There's a black market now created, and the policy largely now becomes ineffective at the problem because you're always catching up. So is there something to be said? More reactive. Is there something to be said for that? Am I making stuff up? Like, what are your thoughts on that?
No. I mean, I think that is a good question. I think there are both more like there are like less extreme versions of that and more extreme versions. I think the less extreme version, which I definitely support, is given existing AI models, you can basically try to probe them in all sorts of ways to figure out their harms. And so like at a lot of major companies like Microsoft or Google or Facebook or Meta, they have probably like responsible AI teams or harms evaluation teams where they are purposefully trying to prompt these models with bad prompts to see how it responds. And so you might try to prompt it with toxic language and see if it produces something bad, or you ask it in like a fancy way, how do you make a bomb or something? And in the right way, you can sometimes get it to give you answers that you wouldn't want it to give. And so I think that sort of harms evaluation is very, very valuable. I think if I understood your question correctly, like a more extreme version of this would be trying to develop AI models themselves and pushing them to the extreme.
Right. That one possibility.
And so I don't know about that as much. I think once you've created it, you sort of let the cat out of the bag. And so I would be more hesitant about that. But I think like given the existence of powerful AI models doing everything you can, especially powerful AI models that have already been released to the world, doing whatever you can to also evaluate them is definitely a good thing.
Yeah, good point on the harms evaluation. I don't think we talked about it too much, but people can go and look into that a little bit more, and we'll include if there's any links to it that you'd want us to share in the show notes too, Serina, we'll be happy to do that.
Cool.
But we're gonna leave it there. Like I said, I don't want to be inconsiderate of your time.
This was a lot of fun.
This show was edited by me, Gordon Thane, with additional editing from LaShawn Benedict. Sound design and mixing by myself and LaShawn Benedict. The original music from The Music Room, composed by Tom Fox, licensed from Johnny Harris. The cover art design for our show by LaShawn Benedict. The Public Health Insight podcast is produced by PHI Media. Thank you for listening to the Public Health Insight podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.